A goal without a plan is just a wish. Considering that I wish to have a seamless experience with phacoemulsification every single time, what I really do, not just have a plan A, but I have a plan B and a plan C. If high IOP phacoemulsification doesn't work, having the same low IOP settings doesn't always work either. That's where plan C of differential IOP comes in. We use high IOP or high bottle height, which gives the advantage of a non-fluctuating anterior chamber. But high IOP phacoemulsification is like a double-edged sword where negatives outweigh the positives. For instance, wipeout syndrome in advanced glaucoma patients, painful procedure in patients with high baseline IOP, larger anterior chamber depth, and greater axial length. There's a higher incidence of lens iris diaphragm retropulsion syndrome in myopes and vitrectomized eyes. There is compromised anterior segment with increased decimatous folds, more anterior segment inflammation, and more edematous corneas. There is difficulty in short eyes. There is stress to the zonules, anterior vitreous phase rupture even with an intact posterior capsule. Will plan B of having low IOP work in these scenarios? Yes. Decrease flow rate corresponding to the IOP and you have a stable chamber. Let's simplify plan B of low phacoemulsification. There is physiological IOP settings with IOP between 18 mm mercury and 22 mm mercury with low flow rate of 23 cc per minute to 26 cc per minute. Supra-physiological IOP settings are IOP of 23 to 34 mm with flow rates of 23 to 35 cc per minute in different steps. Sub-high settings are IOP of 35 mm to 45 mm mercury with flow rates of 40 to 45 cc per minute. In advanced glaucoma patient, I'll be using physiological IOP settings. Side port incision is calibrated with the chopper for extra stability. You can see stable chamber throughout the surgery at physiological 20 mm IOP settings. There is no risk of wipeout syndrome. The case is closed with low IOP. For this patient of posterior polar cataract with pre-existing defect, I'll use physiological IOP settings. There is stable chamber setting. There is no undue deepening of anterior chamber, no undue posterior bulging, and extension of posterior capsule because of high pressure. The low infusion of fluid doesn't push more fluid into the vitreous, thereby not hydrating the vitreous. Minimal pressure difference between anterior segment and posterior segment is making the nuclear fragments float in anterior segment without being pushed posteriorly. You can see that the size of posterior capsular rent has remained the same. I will be using physiological IOP in this patient on tamsulosin with 5.5 mm pupil. Side port incision calibrated to chopper is created. Epinephrine injected for dilatation. Irrigation off of handpieces while going in and coming out. Stable chamber settings with low fluidics helped decrease turbulence by reducing fluid streams and pressure variance in anterior chamber. Pupil size remained the same at the start and end of surgery. In this case of posterior capsular punch with phaco probe, I used supra-physiological settings. Here stable settings with low IOP was used along with low parameters. There is negligible vitreous hydration and vitreous is not being drawn to the tip. Nuclear fragments were floating without being pushed back. Fragments have been successfully taken out safely. There is no extension of posterior capsular defect. In this patient of high myopia, I would be using supra-physiological settings. There is no excessive deepening of anterior chamber, no lens iris diaphragm retropulsion syndrome. The case proceeds as a normal case with decreased pain score felt by the patients. I would be using supraphysiological IOP in this patient of zonulopathy following capsular hook support. Low IOP with low fluidics and stable chamber settings are being used to decrease stress to the zonules, minimize additional zonular tear, and decreasing lesser fluid misdirection too. Yes, we have cracked it. Oh no, we are still missing a piece. It is time for Plan C. Let's understand. There is a corneal endothelial protection with low IOP because of minimized mechanical trauma and OVD retention. However, low IOP phacoemulsification in physiological and supraphysiological IOP settings involve lesser anterior chamber and bag volume, causing more trauma to the corneal endothelium in hard cataracts with increased thickness and with low anterior chamber depths. We build a Plan C of differential IOP phacoemulsification, a combination of supraphysiological and sub-high IOP phacoemulsification. I will use differential settings in hard cataract with increased anterior-posterior diameter and low anterior chamber depth. While sculpting, supraphysiological settings are used. IOP is increased to 44 mm for quadrant removal to increase inflow adequately. At this IOP, increased AC depth increases working space and decreases mechanical trauma. Since moderate fluidics are being used, turbulence in AC is not high. OVD is replenished for corneal endothelial protection. And this IOP is much below the closing pressure of central retinal artery. In this patient with hard nucleus, in white cataract with anterior capsular tear, differential IOP settings were used. Flap motility sign and safe phacoemulsification techniques with low IOP were employed. Low IOP and stable chamber settings decreased the chances of anterior capsular tear extension to become a wraparound tear. And if by any means the anterior capsular tear reaches equator, it doesn't allow fast posterior extension. Concluding, let's use a paradigm of different low IOPs, wherein different IOPs are used in different situations. Different IOPs are used in different steps to maximize patient outcomes. Thank you.